Hi, everyone, and welcome to our May CFAR SBS Core Rocket Talk. These used to be called Chalk Talks, but then we started having them on Zoom. So during the pandemic, we renamed them Rocket Talks. I am Sadie Wilson. I'm one of the Associate Directors of the Social and Behavioral Sciences Core for Duke CFAR, and it is my pleasure to introduce our first speaker for today, Dr. Susan K. Laird. Dr. Laird is a health communication specialist and project director in the Office of Communication Science and the communications director for CDC's Public Health Grand Rounds, and we were there. Dr. Laird has served in a variety of roles in the 15 years she's been at the CDC. She has served as principal deputy in the Joint Information Center for the COVID-19 response. She is a former marketing and advertising executive with extensive experience in all media with types of businesses, including healthcare. An award-winning broadcast writer and producer, Dr. Laird made a 180-degree career change, earning her bachelor's degree in nursing from Georgia State University in 1997. Dr. Laird started working in Atlanta's Grady Health Systems ER, a level 1 trauma center, and became certified in critical care trauma, disaster management, and emergency response while pursuing her master's degree from GSU in adult health nursing, which she completed in 2001. And in 2020, Dr. Laird completed her Doctor of Nursing Practice degree with a project focused on preparing nurses for a role in end-of-life decision-making. Dr. Laird is also a certified professional coach. In her clinical career, Dr. Laird advanced from bedside through leadership roles in emergency departments, from nurse manager in the Emory Healthcare System to advanced practice registered nurse for emergency services at Sinai Hospital in Baltimore. She taught in nurse residency programs and lectured as faculty at Emory and Georgia State Schools of Nursing, where she is currently part-time faculty. She served on multiple ethics committees in hospitals and healthcare systems over the course of her nursing career. Dr. Laird is passionate about community service. She has volunteered as a rape crisis counselor at Grady, as a board member for both Men Stopping Violence and the Atlanta Wind Symphony, and as a Girl Scout leader. As part of a volunteer organization dedicated to healthcare reform in the former Soviet Union, she taught emergency nursing in the Gudushari National Medical Center and the I'm going to mispronounce this probably, Iashvili Children's Center Hospital. Dr. Laird is also a graduate of the Leadership DeKalb class of 2012. She serves on the advisory board for GSU's Burden F. Lewis School of Nursing and is a panel member of the DeKalb County Citizen Review Panel for the Juvenile Court System. Dr. Laird is committed to health equity after witnessing the impact of inequities firsthand in her clinical work. So I hope that you'll join me in enthusiastically welcoming Dr. Laird to our May SBS Core Rocket Talk.
Hi, everyone. Thank you for that introduction. I'm astonished at how long that bio is that you had to read. We have shorter versions. I'm not sure how you ended up with that one. What did we decide to do as far as, I thought you were going to show my slides, or am I uploading my slides? Which way did you want to do that?
Looks like we have your slides. Yep.
Yeah, I did send them. The type's different. Wow, that's magical. Okay. Well, first, I really want to thank you all for being here today and apologize for the first 5 minutes of just bio reading. I hope it was more interesting to you than less tedious for you to listen to than it was for me. But we want to share our passion and our commitment to this work in a way that will entice you to join the effort. I'll try to cover a lot of ground in a short period of time, but know that our ultimate goal is to enlighten as many people as possible to just consider looking at the world through a health equity lens. So thank you for showing up, and let's get started. Now, I can control the screen, it says. I'm trying to figure out where the piece is to move the slide forward. That's it. Okay. I'm not going to read this to you. You know why you're here. And I hope that I will leave you with some information to take with you. Okay, this is where usually there's something I can click on and I don't see it. There it is. Wait a minute.
Dr. Laird, you should be able to click anywhere on the slide to advance.
Yeah, that's what I thought. I'm doing it,
Oh,
but it's not happening. Now
maybe,
I see. Okay, I got it. Well, no, it keeps disappearing. There.
Would you like?
Would you like for us? Yeah, Jamila can probably just advance.
Okay,
the
let's
slides
do
so
that,
be better.
Jamila,
Okay,
because let's do
No
that.
problem.
So next slide. Atul Gawande is a personal favorite of mine, and I think many of you are likely familiar with him. First learned about him with his first book in the Checklist Manifesto, which is showing here. And I appreciate and agree with his take on changes and improvements in healthcare delivery. In his first book, this one, he states it clearly that if we just don't know, then we do the best we can. But when we do know and we don't do the right things, then we have much work to do. The work in health equity and inclusive communication is designed to put us all in the know. Next slide. So why is CDC doing this and why now? Well, when I joined CDC almost 15 years ago, there was already a working group focused on defining health equity. And I remember one of my colleagues talking about the intense discussions. So this work is not new, but there is a renewed focus and commitment, and we're hoping that you're all ready and willing to engage in this work from your own distinct vantage points. Health equity is a public health crisis, and we need to help people collectively understand that. Next slide. Now, CDC launched the Core Health Equity Science and Intervention Strategy, which is an agency-wide strategy that aims to integrate health equity into the fabric of everything we're doing so that all people have the opportunity to attain the highest level of health possible. This core strategy incorporates efforts to address health disparities as a foundational element across all the work that we do in public health. Next slide. Now, I hope you had a few minutes to take a look at the guiding principles. We started on this project in the spring of 2021, so right about a year ago. And we had a very small group of 4, which I was honored to be one of those. We engaged our subject matter experts across the agency and grew eventually to a group of about 16 people that we worked with on and off, and probably what was the most collaborative endeavor I've ever had the pleasure to be a part of. We also practiced what we preach. We engaged a variety of communities, internal to CDC and external partners for validation as well, starting with CDC work groups and expanding to subject matter experts from Emory Healthcare, American Medical Association, American Association of Public Health, and others. So from start to finish, within 3 months, we launched to both internal and external audiences. And on August 25th last year, our web pages went live and we presented at the National Conference for Health Communication, Marketing, and Media that same day. Next slide, please. Now, most of you, likely all of you in this work, are probably familiar with the social determinants of health. And we know that these have a major impact on people's health, well-being, and quality of life. So examples of the social determinants of health include safe housing, transportation, safe neighborhoods, racism, discrimination, violence, education, job opportunities and income, access to nutritious foods and physical activity opportunities, polluted air and water, language and literacy skills. So social determinants of health contribute to wide health disparities and inequities. For example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. That raises their risk of health conditions like heart disease, diabetes, obesity, and even lowers life expectancy relative to people who do have access to healthy foods. Inequities in the social determinants of health are drivers of inequity in health outcomes. But remember that race is one marker of inequities of social determinants of health. And we found that when we talk about health equity, many people consider race as the sole factor. Next slide, please. Now we want to be clear and help people all be on the same page. So this is the basic definition for health equity that we will use. Next slide. Now, the key word for me in this one is preventable. There are things we can change, primarily by addressing the social determinants of health, the actual conditions. Next slide. One really good example was from the beginning of the COVID response. Here we can see that race was a factor in determining disparities for hospitalizations and ultimately even deaths from COVID-19. So what's the why part here? Next slide. And note that while COVID did shine a light on, or additional light, I should say, on the issues of race and social determinants of health, it's not just COVID. We've known that there were much higher numbers of maternal mortality in Black women for years. And these issues often reflect the historical impact of the social determinants of health. Next slide. So why do words matter? Next slide. We know that stigmatizing language can actually hurt people by influencing other people's judgments. Stigma is defined as an attribute, behavior, or condition that is socially discrediting. Stigma is influenced by two main factors, cause and controllability. In terms of cause, when people believe an individual is not responsible for the attribute, behavior, or the condition, for example, it's not their fault or they can't help it, then stigma is diminished. Research has shown that our use of stigmatizing terms may influence judgments, basically that the person's either bad or good, worthy or not, as well as the need for punishment versus treatment. It's important to remember that we personally can't determine the level of pain that stigma causes someone else. Next slide. I really like this example that I want to share with you. So again, thinking of stigma as an attribute, behavior, or condition that's socially discrediting. This is a study where the person on the left was referred to as a substance abuser, and the person on the right was a person having a substance use disorder. So the person on the left was not presumed to benefit from treatment, and that their problem was something innate within them over which they had no control, and that they were more likely to benefit from punishment or be socially threatening and blamed for their substance-related challenges. Next slide. Now, it's no secret that people living with HIV and AIDS have struggled with extreme stigma for decades now, and I certainly don't need to educate this group on the challenges here. Health equity and health literacy and accessibility go hand in hand. Using health literacy principles is one step in addressing these inequities. For example, using plain language, testing materials with intended audiences, providing translation services for people with limited English proficiency, designing websites so that they're accessible to people who use assistive technology. Next slide. Now, there are many lenses that will help communicators work towards improving materials and products. Important to remember that one size does not fit all. You've got to know your audience and do the background work there. What is observable fact? What is subjective? And then be open to improvement, because language will evolve, culture evolves. When you think of accessibility first, it's more than just some of the restrictions, like within the federal government. We have 508 compliance, which means that everything that we disseminate needs to be accessible by a variety of people, including just about all disabilities you can imagine. And that's called, as I said, 508 compliance. But when you think about accessibility, I think it's really important to remember that that's not just people that are hard of hearing or blind. It includes people that have limited access. Like in rural Georgia, many areas do not have internet access, and they certainly don't have access to healthcare. Next slide. So how do we start using these principles to create better communications projects and products? We're developing some checklists that will help, and we'll be making those available to you as well. But here are a few basics to think about. So if you want your product to be inclusive and respectful, then take a look at the health equity guiding principles when you're developing or writing or building a website, putting together a fact sheet. Take a look at that and be sure that you've kept the inclusivity issue in mind. That will help increase the trust from the audience you're making every effort to communicate with. Use the health literacy principles. Again, we have a website on that, very accessible, and has a lot of helpful information. Plain language for the federal government, that's actually a legal mandate that we use plain language in communication. We don't always make it, but we strive for that. And then, as I said, the compliance for people that need to have access and be able to understand what you're doing. Next slide. So I want to go a little bit deeper into the concept of using a health equity lens. Next slide. What does that really mean? The key word for me in this one, it has to do with being intentional. If you look at your messaging and your materials to identify potential positives and negatives that may impact your audience, this will help you be more effective, and that's your goal, right? So get input from your intended audiences. Ask them how they want to be identified. How can we be useful? That's what we did in the development of the guiding principles. We asked working groups at CDC to start with. Using a health equity lens in communication planning, development, and dissemination means intentionally looking at all those potential positive and negative impacts of proposed messages on everybody. The goal is to be inclusive, avoid bias and stigmatization, and effectively reach those audiences. So ideally, you're going to get input from your intended audiences. Next slide. Now, these are the core components that you would use to ensure that you are looking through your work in using a health equity lens. This is just the foundational information, and you'll note here where it says health equity is intersectional. I'm going to talk a little bit more about that later. Let's look a little bit deeper into these. Next slide. So these are 3 questions to ask when you're talking about using a health equity lens. I knew the dog couldn't resist being quiet during this entire thing. I won't yell at him, it won't do any good. So the first one, next slide, please. So how are social and health inequities at play? Most of us in this work environment are aware of all of these contributing factors. And some of these may even seem redundant because they all lead back to the same problems. But I want to point out the significance of our own assumptions and biases. These evolve from the way we were raised, our exposures to different cultures and experiences, and these all play a major role in how we perceive others, both positively and negatively. Next slide. So how should planning and implementation of the activity be responsive to inequities? Well, this health equity lens helps us see beyond our own world by engaging our communities and populations of focus in the decision-making process. People and groups appreciate being asked about their worldviews, and when we ask, we almost always learn something. Next slide. So this is really a good question. Will or does the activity perpetuate existing inequities? So while you're planning something, if you're going to do this activity or take this action, will you unintentionally cause problems? Are you overlooking risks or benefits? And is your message saying what you want and need to say? And are you staying within the appropriate context? Next slide, please. Well, this is one I really love to share. This is about the intersectionality piece, and I was looking for a graphic that might demonstrate what that means. So I started with cdc.gov. Of course I did. Why wouldn't I? And this is what came up first. And this is from the CDC Injury Center, and it's a call to enforce red lights. And I was kind of dumbfounded, to be honest, that that was all I found. I had to really dig deeper. And as I said, once I got over the initial shock that we didn't even have anything on intersectionality, I thought, clearly there's a gap in information there. Next slide, please. So I found this one, and I think at its most basic, that clear definition of intersectionality is that people often, and in fact usually, belong to more than one group. So people may belong to more than one group that has historically and currently faced discrimination. We should consider this in our analyses and communications. So as one example, a Black woman may experience discrimination based on her race or gender. She might identify with experiences of white women as well as with the experiences of Black men, but her experiences as a Black woman might differ from either of the other groups. So let's just take me, for example. I'm a wife, a mom to adult daughters, a mother-in-law to their husbands, a grandmother, ER nurse, and a health communications specialist. Just those things covers quite a bit of territory, and I wouldn't want to be thought of in only one of these realms. So, and I doubt you would either. So I think that when you might want to start and go through this exercise and you think about yourself, what comprises you or represents you. Next slide, please. I'll talk a minute about engaging with the audience, which is, again, we'd like to try to practice what we preach here. So our Agency for Toxic Substances and Disease Registry, otherwise known as ATSDR, which is a sister agency, has done some great work in community engagement already. Next slide, please. So they have 9 principles of community engagement. Awareness of the various cultures of a community and other factors affecting diversity must be paramount in planning, designing, and implementing approaches to engaging a community. Community engagement can only be sustained by identifying and mobilizing community assets and strengths, and by developing the community's capacity and resources to make decisions and take action. Organizations that wish to engage a community, as well as individuals seeking to effect change, must be prepared to release control of the actions or interventions back to the community and be flexible enough to meet its changing needs. So in other words, or in summary, first you've got to ask them what they need and what they want, and then you help them achieve those things. But then finally, the control of it has to go back to the community in order to really implement the work. So community collaboration requires a long-term commitment by the engaging organization and its partners. Next slide, please. Now, there's a lot of conversation now that says that generations no longer make a difference. I think we're leaving out a significant contributing factor if we don't understand that generational perspectives are important. We work in a 4-generation environment. Understanding the different points of view will help us frame messaging to fuel change. In Lynn Lancaster and David Stillman's book, When Generations Collide, they identified drivers of perspectives based on when people are born. So for example, people from the Depression era may have experienced hunger. One example from my own life, my father was a World War II veteran who served in the Pacific Theater. And he had this extreme hatred for Japanese people his entire life. It did not matter what we said or did to change his perspective. He was never going to move beyond that. And we never saw anything else from him. It was not even a topic we could discuss at some point. Baby boomers remember where they were the moment Kennedy was assassinated. I certainly do. And 9/11 cuts across many different generations, but most of us continue to feel the impact of what happened that day. These perspectives greatly influence management and leadership styles too. The book is old now. It's probably a good 20 years old. I had attended a workshop that Lancaster and Stillman did back around 2006, I think, but the message is still worth a look. So the book's called When Generations Collide. Next slide, please. Now, another area that needs to be addressed is humor. Last year, People magazine did a feature story and an interview on Gabrielle Union. They asked her directly about the issues of racism in Hollywood. This is a great example. Blackface in musicals were very popular in the 1930s and 40s. So children of parents who grew up in their households would not always know that blackface is inappropriate. There have been multiple examples recently of people, including well-known political types, showing up in parties in blackface. It's not funny anymore, if it ever really was. And most of us, I think, can think of examples where we once laughed at jokes that no longer seem funny. Next slide. So I want to talk for a minute about the purpose of the guiding principles. This work is hopefully both inspirational and aspirational. We hope to start the discussion, and we hope to start your thinking about this work so that we can collectively reach our goals. In the process and after the launch of the guiding principles, we received both feedback and pushback. I guess the difference in those two are that the feedback was constructive and we made changes to reflect good ideas. The pushback, not so much. Pushback that came to our email box, some of it was harsh, even mean and threatening, and a few even used our suggested words to basically attack us. Next slide. I'm assuming some of you watched the Super Bowl in February, and Billie Jean King, the first female athlete to receive the Presidential Medal of Freedom, tossed the coin to mark the 50th anniversary of sports gender equality legislation, Title IX. In her acceptance, she noted that it's hard to understand inclusion until you've experienced exclusion. I think that's a good place to start, with an understanding that this work is hard. Not everyone will be supportive and not everyone will be understanding. Despite the progress we've made since the 80s, there continues to be a stigma against people who live with HIV and AIDS. In the early 2000s, as a nurse manager in the very large ER in Atlanta, I had a male nurse that would literally hide every time a patient with that was HIV positive or had AIDS come in. He would manage to be at lunch or breakfast or something so that he didn't get assigned an AIDS patient. It was tragic in my worldview. But again, this was 2000. I think it was 2003, and it was. His impression was not going to change. And I'd rather have the patient have someone that would provide appropriate care than continue to try to rationalize with someone who was just not going to get it. Next slide, please. So let's talk about the health equity guiding principles, what it is, what it's not. First, it's really important to focus on the foundational concepts, not the preferred terms. The terms are just examples, and as we continue to say, they're not prescriptive and certainly not the only options. There are no mandates. It's a reference. You don't have to use these exact words, but we think you should give them a chance. And we learned that there were supervisors at CDC that were telling people that they had to use these terms. So I want to repeat, these were never mandated at CDC, and certainly we're not suggesting that you make them a mandate in your organizations either. And there may be better terms that apply to your population of focus. So the guiding principles emphasizes the importance of addressing people inclusively and with respect. Next slide, please. These are the foundational principles themselves upon which the rest of the work rests. Reframing, reframing messaging to be aware that what we say about others has an impact. And we want those messages to connect with our audiences. We've referred to target audiences and vulnerable populations for so long, it's a habit. And changing habits takes effort and energy, and it will not happen overnight. Next slide, please. Again, I want to stress that these are recommended terms to start thinking. So when you're writing something or anything from a presentation to something you're going to disseminate, go back through that health equity lens and think about what you're saying and who you're saying it to. Remember that people will totally focus on the actual words we suggest versus the intent. So listen to your audience and use the lenses that we've talked about here. We find that one great example is in pregnant people. We get this question almost every time I do a talk. it shows up in a lot of the pushback we received, that we're trying to be politically correct. And why are you saying things like pregnant people? Well, we ultimately decided not to include this term in the guiding principles. The intent of the term is to be inclusive towards a transgender audience, perhaps, but the risk of offending pregnant women is currently very high. So when we weigh the potential impact against our intended audiences, we make a decision based on who's going to benefit most from the messaging. Currently, we'll say, why don't you say people who are pregnant, or if you are pregnant? So unless you're tailoring your message toward a more specific audience, that's usually a better way to remain inclusive and yet try to be the least offensive that you can be. Next slide, please. Now, the first thing when you're talking about using preferred terms is to think about the adjectives you're using. So instead of saying high-risk groups, you might say groups with a higher risk of whatever, COVID. Name your challenge, but it's a person first piece. Next slide, please. So person first language. It can be very challenging at times, and some say it adds more word to the message, which is a problem, especially in social media like Twitter, where you have controlled numbers of characters. It may, but the trade-offs we believe the trade-offs are usually worth the effort. So instead of the homeless, which categorizes everyone in a certain box, if you'd say people experiencing homelessness, then it's less pejorative towards that population of focus. Next slide, thanks. Yeah. Now this is an old quote from the business guru Peter Drucker, but it deserves revisiting. Culture will rule every time. When possible, translate your materials into the preferred language of your audience. And as we've said many times, engage the community. Note that culture is not only about language, it's also what drives behavior, and it will win. Next slide. There's a new focus on mental health, and that is really a very good thing. Discussing mental health was taboo for such a very long time, and we're talking about things now that we've never talked about before, mainly thanks to people like our Olympic gymnasts, professional tennis players, etc. Now those celebrities have that they've identified that they suffer from these concerns. It may be less stigmatizing for others to openly discuss the concerns and needs for all of our communities. Next slide. Now, as a person who doesn't relate well to being called elderly, I have a few suggestions here. As we age, we are indeed at increased risk, but there are miles and miles between me and the nursing home. At least I hope so. So if you want to reach these audiences, think of different ways to categorize people. We're not all sick. One pet peeve of mine, when healthcare providers come into a room in the ER and they see an older person, maybe with gray hair and some wrinkles, they immediately start yelling, raising their voices in the assumption that the patient's hard of hearing just because they're older. So be aware that age and associated risk are often on a continuum. Risk for many diseases and more severe outcomes do increase with age. Tailor guidance to specific settings when appropriate, such as long-term care facilities. Signs and symptoms of diseases may be atypical, delayed, or attenuated in older adults. Caregivers are also often older adults, and they may have additional risks as well. Use audience-preferred channels and platforms, and remember that not all older people are hard of hearing. Next slide. So we need to address the importance of choosing appropriate images. Next slide. Now this one, I just love this one because I did a Google search on Shutterstock, which is great companies. I'm not picking on the company here, but when I searched just for doctor, this is what I found. It was the top slide. So not a whole lot of diversity here, very minimal. And I'm sure that if I had continued searching, I would have been able to find something that was a little more representative of doctors that we need to have. But I found this one to be, it was almost, so as I said, it was the first one that came up. So it didn't surprise me to find that, however. Next slide. So a picture is worth 1,000 words. I've heard that somewhere. I think you probably have too. We want to be sure that pictures and graphics are given just as much attention as words and language with regard to how we represent our audiences. Next slide. This is a matrix that it's a tool we've developed to help determine if your graphics are going to be given the thought needed. And we're in the process of developing a tool you'll be able to download from our website and use it as you evaluate graphics for your next work. Next slide. Important that we have a couple suggestions for how to implement these concepts in your workplace and even in your own home and social universe. So again, don't focus on terms. Allow opportunities for people to make adjustments. What does this really mean? Go back to one of the original statements that not everybody comes from the same place. Nothing is set in stone and practice makes perfect. So what is your personal contribution to the effort and what matters to you? Next slide. In order to make it stick, you need to start using the health equity guiding principles, refer to them before and during the development of your communications materials. Look at all the materials through a health equity lens and look within your own organizations and definitely look within yourselves before you look outside. Next slide. This is not a finished process. It's important to understand when and how culture changes. Listen to learn when language changes. Incorporate communities into the process, our learning process. Build relationships with communities to obtain their input and invite them to be part of solving the problem. Next slide. Look at places where the work needs to be considered. Some of your web pages may need a serious overhaul. Inaction perpetuates the problem. So taking a general approach will not correct the inequities. Be intentional and specific and challenge the status quo. Next slide. One of our biggest challenges is determining how we're going to measure success and how will we know that we've made a difference. It can take generations to make behavior change, and change takes time. There are policies and procedures that CDC and other organizations can leverage. So how serious are our organizations' commitment to health equity? What can we change? It starts with you. So set up your work for future evaluation. Don't wait to do the right thing. Next slide. Consistency is going to be a major part of making it stick. Strive to have an open mind personally and collectively. Be willing to listen and adapt to the changing climate and use a health equity lens across all your work. Next slide. Not everyone's going to get it. Your organization is a big place, most likely, like CDC, and just because we all work there, it doesn't translate into all of us thinking the same thing or talking the same way or behaving the same way. And maybe you're struggling personally with some of this. So invite others to the table. Continuously engage colleagues to discuss content and implementation. Increase understanding to obtain buy-in. And remember that forgiveness and encouragement are a lot more effective than blaming and shaming. Let's go to the next slide and we can skip that one. And then we lost probably the greatest champion for health equity back in February, but we can still learn from him. Next slide. And that's it. I'd gotten the notice that I was running out of time, so I wanted to be sure that I wrapped it up. I don't know if we have any time for questions or if you would like me to hang around in case there are any questions. You can also email the box or me personally. And if you have a question you didn't get to ask or you thought of afterwards, I'm more than happy to respond to that.
Thank you so much, Dr. Laird. That was wonderful and so informative. So what we're actually going to do is we have our two community representatives here. We were hoping to sort of have them as discussants, and then as folks have questions for both them and you, we could sort of field those questions as they come up.
Sure.
Would that be okay with everybody? Great.
Works for me.
Great. So Lizzie was going to introduce our two panelists and then invite discussion in the group.
Great, thanks so much. My name is Lizzie Knippler. I work with the Duke CFAR and support our community engagement efforts. And I'm happy to introduce two community members to help us continue this conversation and speak a little more about language and some of these principles and provide their perspectives and expertise. So happy to first introduce Alicia Diggs, who is originally from Philadelphia, Pennsylvania, and describes herself as a mother of 2, a glam mom of 4, and a fur mom of an orange tabby named Xander. She has been thriving as a woman living with HIV for 20 years and has a background in both social work and public health. She's an author and a member of various national organizations in the HIV movement. And she is the manager for the Office of Community Engagement for the North Carolina Chapel Hill Center for AIDS Research. We also have Terl Gleason, who I know from his involvement with the Community Advisory Board, the CAB, that has worked with the Duke CFAR. And Terl is a person who has lived with HIV for over 30 years and is a founding member and executive director of Advocacy House in Greensboro, North Carolina. Advocacy House is a community-led nonprofit organization, and all of their 13 board members are living with HIV. Terl says that language is one of their favorite things to teach and is Advocacy 101. They've done a lot of work to help educate community members about the importance of using language to address stigma, both internalized and external. So you can see why we're so thrilled and very grateful to have Ms. Diggs and Mr. Gleason here to help us continue this conversation. And I just want to start us off just by asking for your responses to kind of what you've heard and any thoughts that you had, or additional things that you would want others, including clinicians or the researchers or the CDC, to consider when thinking about language or some of these principles.
Terl, you can go first.
Thank you, Alicia.
You're welcome.
Hello, everybody. My name is Terl Gleason. Thank you for having me. I'm a person who's had HIV a long time, and I'm really glad that health department, CDC, and folks are interested in language. In the beginning of this, we were all educated at our doctor's offices, and so we all learned stigmatizing language. We all thought we were infected. We all those negative words, that's all we knew. And so as we've grown with language, what we've done is we've termed that we have 2 languages. We all know clinical. Everybody in this group knows clinical HIV language. What we're trying to learn, and I'm excited that you folks are, is community language. You know, I have HIV, not I'm HIV infected. So I've always looked at it as it's no fault, guilt, shame, or anything, because everything you're reading comes down from the CDC in that language, comes to the health departments in that language, comes across our emails in that language. And so a lot of people don't know that they could be saying things differently. And so I'm excited that you're wanting to do this, because all that's going to happen is that you're going to have more community connectivity. When people realize that they can talk freely and that you understand what's going on because you're talking that way, you're going to get more out of it. And I hope I answered the question. Thanks.
Thank you, Terl. And to add to that, it most definitely takes away the stigma on both ends. As Terl indicated, you know, we all remember all of the language. I remember the language, and even recalling back 20 years ago, hearing the language, it was stigmatizing then. It hurt then. And it made conversations extremely difficult to have with your doctor, with your family, and most definitely with somebody who was a prospective partner. Mm-hmm. And, you know, I know for me, I just did not want to have the conversation because I already knew there was a stigma behind HIV and there was going to be rejection. So as I grew in this movement and I grew in my language, it gives opportunity for me to not only educate my community members, but I educate the people that I work with in the medical field. So, you know, even if over the years I have come into contact with a physician that I've worked with who was providing me care, And, you know, they used language that, you know, I felt was still stigmatizing. And while it may not have bothered me, it may have bothered the previous patient or the patient after me. What we do now in the community, instead of calling people out, we call out the language and we call the person in.
Right.
And we help to educate them. So it helps everybody along the way. And like Terl said, I am so grateful that we are having this conversation, not just as community, but also as science and as everyone working in the healthcare field.
Just had to write down what you were saying because I think it's something we can borrow. So we'll attribute, you know, but calling the language out and calling the person in, I think, is a great summary from what I just talked about for 45 minutes. So I think when we talk about engaging the community, this is what we mean. And so I don't know why it's hard for people to do it. It may be just because I had a different background to begin with, but I do think nursing as a profession, it does a better job. I could be mistaken. I called out the one nurse that, I mean, seriously, he was terrified. And he would run and I would be, I don't want to put you with someone living with HIV or AIDS anyway, because you're not going to take good care of them, you know? And so he was successful in getting what he wanted, which was to only take care of people who really weren't that sick, you know. But it was interesting to see how it got better. So I was first a nurse in '97, and even though CDC was originally engaged in AIDS in the early '80s, there's a project I work on called We Were There, which was mentioned in that 5-minute bio. I apologize for that. I don't think I said that, but in any event, you could watch it. It was very interesting because it was featured Harold Jaffe, who wrote the book called And the Band Played On. And it's an event called We Were There. You can find it at cdc.gov/We Were There, all one word, no spaces, where he talks about how it was to discover HIV, and also talked about the government not doing a very good job. And it wasn't that CDC didn't, he was talking about President Reagan, where the impact of government taking a very almost adversarial position to the situation instead of doing what we're trying to do in public health today. It's kind of interesting. But thank you for your remarks, and you as well, Terl. I think, you know, when you talk about living with HIV for 30 years, and Alicia for 20, you're talking about experiencing quite a lot of ups and downs, and how in the evolution of how we're looking at it now. And I wish you'd share more of that experience, because I could always stand to learn more.
Yeah, so I think we have a question, but I also think that Terl was going to say something, and Alicia, maybe you were going to say something as well.
Yeah, I actually was going to say, just to piggyback on what you said, things have changed over the years. And while the science proves that things have changed, as we talk about U equals U, that science proves that things have changed. And it's wonderful when you see the healthcare system as a whole change with that science, not just the community members. And I will also add, not everyone can receive and will receive a undetectable status. But what we do as community members is we continue to empower and uplift our fellow community members to help them understand the importance of staying in care, getting in care, and build a family, regardless to how different we are in our different communities, but we all are still the same because we're living with and affected by this disease. So it's important for us to come together as a unit to make sure that each and every person in the community understands we're in this together and we're here to help you. Even though Terl and I come from different backgrounds across the tracks and all of that, we work together as a team so that, you know, we can help our fellow person in Guilford County or in North Carolina, wherever, to know that we are here and we are making a change, and you are a person and you are important.
Thank you so much, Ms. Diggs. And Mr. Gleason, were you gonna say something too?
Yeah, I can say a lot. I don't, what's the question?
Well, actually, I think we did have a question from Michael. Michael, did you have a question?
I was just going to thank Mr. Gleason for the comment about the clinical language versus community language. And as a nurse, and it's such an important distinction. I've never heard it separated that way. That many times I've struggled to help my fellow nurses and other healthcare providers to try to use different language. And I remember having a conversation with someone that, well, yes, that's clinical language. And they kept saying, but it's factual, it's true. And I didn't know how to respond, and you helped me. So I just wanted to say thank you and ask both you and Ms. Diggs, are there other words of wisdom that you would want to offer us? Many on the screen are involved in HIV research. What other kinds of things would you want us to think about in terms like informed consent, research, language, and that kind of thing?
I know I would like to add that, and this may sound really simple, but when you think about a person who has diabetes or a person who has heart disease, you don't name that person by the illness that they have. And when you look at all of us who are those people who are living with HIV or affected by HIV, for many years since the beginning, we've been looked at as the disease itself instead of the person, whereas the person who has other illnesses are looked at as a person before the disease. And I just kind of charge everyone to look at everyone as a whole that way, as a person. So when you're doing, your reports or your grants or research or what have you, see us as people first, as we talked about in the Denver principles years ago. It's just so important, and it's going to make a difference in people not feeling so stigmatized, set apart. It's going to help people feel empowered and feel like you really care. And it's not so much as, the work. Research can't be done without us. And it's like we're all a team. We're all a team together. So if we work together as a team, I'm pretty sure we can end the epidemic, and we could really just bust things wide open when it comes to research and better medication and better access.
Michael, thank you for what you said about the community versus clinical language. That is something that we came up with on the ground. I don't know if anybody else is saying that, but it's really, it's a tool to help clinical people, think about it. And probably the easiest way is if you're not talking with an epidemiologist, you're talking to grandma. Grandma's not going to understand anything, except, so just if you can take it to that level where you're not talking peer to peer. But then here's the other problem. You're going to have to go back to peer because y'all are doing paperwork, you're doing reports, you're doing stuff that is 100% clinical. Yeah. So it's just, I guess, acknowledging that how do we reach this community? I mean, the first time one of my doctors said to me, high risk behavior, I was shocked. I didn't know that I was involved in high risk behavior. To me, it was stimulating and fun behavior. So it's just a matter of perspective. And I guess the easiest way to do it or to think about it is to just take out every clinical term there is and see if you can substitute it with something else. And it's hard. It's very hard. Yeah. I sent a little cheat sheet over, and you can't really see it here, but this is old language. Alicia knows. This is 2012 information, and it's evolved. And so it's old because it's mainly full of stuff like full-blown AIDS, infected, things that are old. So
can you send that to me?
Lizzie can.
That would be.
We'll absolutely get on that. Yep.
Yeah.
Right,
Thanks.
Thanks.
I added a more up-to-date link in the chat that has some up-to-date language. It includes what Terl has in front of him, as well as some newer information or newer words. Another, like Terl mentioned, I know we're running out of time, but like Terl mentioned, the word risk doesn't mean the same for everyone. Like risk, when Terl heard it, was like, oh, wow. And for me, you know, being a woman living with HIV and diagnosed 20 years ago, I didn't know or believe or even feel that I was in a risky, you know, situation or in relationship because I was married. So, you know, think about that as well. I cannot say that we've come up with a better term than using risk, but there's something that I think we all need to think about in the community as well as science when it comes to that particular word, because you lose a lot of people, even engaging cisgender women with PrEP, you're losing them because you're saying risky behavior, and they're not seeing themselves as risky. So that's just a little bit of wisdom to throw out there or suggestions.
Or what about living in a target area? Where's the bomb? You know, like you're in a targeted area.
And we ask that you use focus and not target, but focus.
Right.
Focus.
Yeah, I mentioned that one because that whole the whole target language, we've been working on getting rid of that and referring to population of focus. But I'm doing a talk in a couple of weeks, and I'm going to quote you guys. I promise to give you attribution, but it's to the National Public Health Information Coalition. So it's a pretty big group, and it's a lunch and learn session that's more conversant as opposed to just a presentation, and I'll have opportunities to bring in some of this stuff. But this is great. This is very helpful.
I'm going to add one thing since you brought up a quote on the, Lizzie, don't forget to send the back of that sheet, because there's a great quote on it from Mark Twain. And it's the difference between the right word and the almost right word is the difference between lightning and the lightning bug.
I love that. I haven't heard that in years. I'm a big Mark Twain fan. So that, yeah, I will use this stuff. Trust me.
Well, I want to thank all three of you. So will you all join me in thanking Dr. Laird, Ms. Diggs, and Mr. Gleason for a really engaging presentation and panel discussion. And I believe there are a couple of, let's see, so I think we have Dr. Laird's email address in here. If there are questions for Ms. Diggs or Mr. Gleason, can those go through our SBS core? Would that be okay? Or, okay, Ms. Diggs put her contact in there. Thank you. Don't feel like you have to, Mr. Gleason. Okay, Mr. Gleason will as well. So again, thank you all so much. This has been a really engaging session. It'll be available recorded if you want to recommend it for other folks to tune in and watch it if they weren't able to make it today. Thanks again, and we'll see you all in the new fall semester for our next Rocket Talk.
Thank you.
Thank you so much.
Everyone.
Thank you for the opportunity.